So the question facing a clinician is, if they want to administer neoadjuvant chemotherapy to a patient with stage 2 or 3 triple negative breast cancer, should they add carboplatin to their standard regimen? And I think the updated results of the study really don't change that equation. I mean, what the study has shown is that, yes, adding carboplatin does increase the pathologic complete response rate by about 14% absolute. And that's a statistically significant, and in my mind, a clinically significant increase. We don't yet have any data as to whether that's going to translate into improvements in long-term outcomes such as relapse-free survival or overall survival. And what we haven't found yet is a subgroup of patients who either get a larger benefit from carboplatin or who don't benefit from carboplatin. And so while we're doing additional analyses of the study, and we may come up with that sort of subgroup in the future, at this point, the decision to add carboplatin or not is basically the same as it was after last year's presentation. For bevacizumab, the story is much more complicated. First, bevacizumab is not generally available to use in patients with in the neoadjuvant setting, and its overall role in breast cancer is up in question. But it does raise the possibility that we might be able to identify a subgroup of patients who gets a larger benefit from the addition of bevacizumab. And I think if we look at other studies as to whether that is confirmed, we may allow us to go down the road and say, okay, maybe there is a subgroup of patients in whom we really should be using this drug.